So just before we talk about acute blood loss, let's actually talk about what is in blood. So here's our whole blood, and we centrifuge that down and we get our red cells. We get a buffy coat layer, which has our white blood cells and our platelets. And we get plasma, which has numerous things in it, but what we care most about are our proteins, because they are very large and so more relevant when we talk about blood loss. And we have relatively equal proportions of albumin and globulin. And of course, when we lose blood, we don't just lose red cells, we lose it all, right? So you lose all of the blood in similar proportions, and so that is why we also look at proteins when we're looking for acute blood loss. So let's move on to our patient here. So this is our patient who's just suffered some sort of very bad trauma and is bleeding. And many things happen when you start losing all of these red blood cells. And one is that they, of course, carry oxygen. And so the first thing that happens is you have decreased oxygen carrying capacity, which results in decreased oxygen in the body. And so your body responds to that, obviously. And we've talked about that a little bit. And your body responds by your kidneys making erythropoietin. Your kidneys make erythropoietin, and they tell your bone marrow to make red blood cells. But of course this doesn't happen right away, right? So your red cells have to start being made in there, and so it's going to take a few days. It will take around 2 to 3 days to see anything in terms of regeneration. So another thing that happens, especially with trauma, is your spleen can contract. And of course your spleen contains numerous red blood cells. It has a very high PCV of 70 to 80, and it also contains platelets. It stores platelets, and so you get a release. So this was item number 1. Item number 2 is splenic contraction. And this is really in trauma and in acute blood loss. So splenic contraction releases these red cells and potentially platelets, and you may then not see the anemia immediately within that first hour, or it may compensate within that first hour. Another thing to realize is that, again, you lose all red cell components, and so you may not have an obvious PCV decrease. Certainly your patient is going to be clinically will have signs of decreased oxygen carrying capacity, but at first, until you have fluid, either administration or redistribution, numbers of red cells and the amount of protein is less but still proportional. And of course the PCV is a proportional number. And so what happens next is fluids, and again this is either administration or redistribution. So fluids are administered, hopefully they're not given sub-Q in an emergency. So they're administered, and to fill back up this space, which is obviously going to dilute out the remaining red cells and proteins. And so what you then see, along with your decrease in PCV, is you see a decrease in your total or plasma protein with concurrent and relatively equal decreases in albumin and globulin. So then how do you actually identify acute blood loss? Well, clinically, you're going to assess your patient, and if they're hemorrhaging, that would be your first clue. But of course, on blood work, you may not have that information potentially. So you're going to have, obviously, a decrease in PCV, so you're going to have anemia. You're going to look for a concurrent decrease in total protein. You can actually, weirdly enough, have a decrease in platelets, which might seem counterintuitive given the splenic contraction, but platelets, their job is to stop clotting, and so they actually get consumed in bleeding. And so you can have a mild to moderate thrombocytopenia, meaning a mild to moderate decrease in your platelet number. So that may or may not be present. Because of the splenic contraction, however, though, sometimes you could even have a normal, rarely high platelet count, but often in acute blood loss, especially ongoing acute blood loss, you expect to see a mild thrombocytopenia. Something else that could support hemorrhage would be an increase in BUN with a normal creatinine. And that's because BUN, urea, comes from ammonia, and ammonia comes from protein breakdown in the GI tract, and blood is essentially a protein, and so with GI hemorrhage, you can have an increase in ammonia production, which then increases urea production. So speaking of platelets, if you're looking for causes of bleeding, very, very, very severe thrombocytopenia, where it's less than 25,000 platelets, would actually support, that would then be the cause of the bleeding. Other causes include, again, trauma, blood vessel trauma, neoplasia, GI parasites, hemostatic abnormalities, and we'll kind of go through those as we go through the cases.